I'm a haematologist. That means I treat blood disorders, and I'm a consultant with the Trust, but I also work at the University of Oxford. It's terribly important, though, that patients get involved. It's important that you come to things like this. It's important you make your views known about what matters to you in terms of where we're going with research, what we're doing for treatments, what are we covering, what are we not covering. We've got to hear your voice. And unless we hear your voice, we might be going on tracks and alleys that actually are not the most important for your care. I thought I'd just spend 2 slides saying what leukemia is. Let's start from the sort of beginning. Every day, all of us, we make about 10 billion new blood cells in our bone marrow, which is our blood factory. And it's quite a prodigious task if you think about it. I can't think of a factory on God's earth that makes 10 billion new saucepans or cars or whatever you want every day for 80, 90 years perfectly. And not only does the blood factory do this, it does it to demand. So if, for example, you bleed, your body has to make more red blood. If you get an infection, your body has to make more immune cells immediately, within hours. So it's pretty amazing that this production goes on all the time. And what's remarkable actually is it doesn't go wrong more often than it does. And here I'm just showing you what a bone marrow sample looks like. So we do maybe, I don't know, 5 or 10 of these every day. And what we do is we pop a needle through the pelvis, through the side, through the hip here, and we suck out a bit of the marrow and spread it on a slide, like this. And what we get are little particles, which we call fragments, and trails that come down, and most of this is just blood. And when we look at these particles here, they're like this. And coming out of the trails are all the different blood cells that you make every day. So here you can see red blood cells. These are these ghost-like cells here. You've got about 100 billion of those in your blood. You've got these white cells, they fight infection. This little donut-shaped thing here, this thing here, all of those fight infection. And this very complicated looking, unusual type of cell makes what we call platelets, and they stop you from bleeding and bruising. So we just look in the trails here and you can see thousands upon thousands and thousands of blood cells. That's your bone marrow, that's your blood factory. Okay, and sometimes this prodigious production of blood cells goes awry. And sometimes we make too many blood cells in an uncontrolled fashion. And it usually starts with only one cell going wrong. And when that one cell, very early at the top of the hierarchy if you want, it produces daughter cells that are all wrong and they grow abnormally. And that is what leukemia is. It's really a cancer of blood cells. At the top of this hierarchy of production of blood is a parental cell, if you want, a sort of grandfather cell, the cell that makes all the other cells in blood. And we call that a blood stem cell. Now you may well have heard about stem cells in all sorts of contexts in the national press. But a stem cell is really that. It's the stem, it's the start. And just as you have stem cells that make gut or kidney or lung or everything else, you have stem cells that make blood. And this one cell will divide to replicate itself, but at the same time it will produce daughter cells. And these produce granddaughter cells if you want. And these then produce finally the mature cells that you saw in the slide before. Red cells that carry oxygen, that give blood a red colour, They're red because they have a pigment that carries the oxygen. White cells, these are very much like the army. They fight. Some fight bacteria, some fight viruses, some fight fungi, but they're there to keep you safe against the environment within which you live. And finally, that very unusual large cell that I showed you, the megakaryocyte, that makes little tiny things called platelets. Not many people will know about platelets, but they stop you from bleeding and bruising. And we need those. If we didn't have those, we'd come out in bruises almost in an uncontrolled way. Now, what happens in leukemia is that very early on, right at the top of this hierarchy, you acquire, in most cases, changes as a consequence of the environment within which we live. Changes in key genes. Now, genes are a bit like codes. They're instructions. They tell the cells how to grow up normally. So if you mess in very, very important cells right at the beginning with the instructions for this program of cell production, this program can go wrong. And so here you can see immediately, instead of just dividing into 3, you've now divided into 9. And these 9 cells shouldn't be there. There should be less of them. But it's not a disaster. They can still grow up. They can still make cells, blood cells, and they can still give you a normal looking bone marrow. But this is what we mean by a pre-leukemic condition. This is a condition which, if you acquire additional damage, will cause problems. But already you can see that there's something not quite right. Now, we don't normally get to see this picture, because why would you look? The blood looks normal, the marrow looks normal, patients don't have any problems. In fact, they're not patients. There's Joe Public out there. But occasionally, folk do get into problems, and we see this condition, this pre-leukemic condition, in very select circumstances, and I can talk to you about that. Now, if you were to acquire additional damage in terms of genetic change, you can now get a permanent block here. So instead of progressing and marching through and growing up and making adult blood, you now have serried ranks of these immature, unruly adolescent cells. Okay? And they're just like adolescents. They wreak havoc. They destroy your bone marrow. They don't allow a normal progression of blood cells to be made. And you can't live normally when your marrow looks like this. And that is what is leukemia. And it's a gradual, stepwise process. I've just shown one intermediate stage here, but in reality there are many intermediate stages with a gradual drifting away from normality into anarchy. How common is leukemia? Now, we've heard it's the most common childhood cancer, and I'll show you that data in a minute. We've also heard it's the 12th most common adult cancer. It represents really 2% of all cancers, excluding very benign skin cancers. So if you take benign skin cancers, moles and things like that to one side, and look at the bulk of cancer, it comprises 2%. But blood cancers in general, not just leukemias, but some of you may have heard of lymphomas and other such blood cancers, they account for about 10% in total. Leukemia specifically accounts for about 2%. So you might argue, well, this is a small problem. Of course, it's not a small problem from the people who suffer from it. And, as you'll see, it does cause problems. In 2006, about just over 7,000 people in the UK were diagnosed with leukemia. So it caused about 4,300 deaths in the UK in 2007. And today I'm going to talk mainly about a type of leukemia that we call acute leukemia. Acute leukemia is a type of leukemia that can cause problems and symptoms quickly. And that's simply because the leukemic cells grow quickly. So if I was to show you this, these cells in acute leukemia would grow very fast, and you'd go from here to here in a matter of months. In contrast, chronic leukemia, which is a little bit more common than acute leukemia, usually causes problems and symptoms over time, often over many, many years. And that's simply because the leukemia cells grow slowly. Okay, so today I'm just going to talk a little bit about acute leukemia. It's what I mainly treat, and it's where I think there are lessons to be learned, and I think Oxford can make a real contribution. Let's talk about children. Now, in childhood cancer, acute leukemia is the commonest childhood cancer. Around 300 children a year are diagnosed with acute leukemia in the UK. And if you look at the rate per million, this is a form of acute leukemia that we call acute lymphoblastic leukemia, and this is a form that we call acute non-lymphoblastic or lymphocytic leukemia. You see the bulk of the children with this condition are aged between 1 and about 8. Small numbers, but in terms of childhood cancer, still the commonest. However, over the last 4 decades, the treatment of childhood leukemia, in terms of survival, has been a success story to celebrate. And the treatment of childhood leukemia has dramatically improved survival. Back in the 1960s, about 20%, less than 20% of children were surviving. With the advent of chemotherapy, these are very powerful drugs, the survival in the late 1960s through to the 1970s jumped to about 48%. Further improvements were made in the 70s and early 80s, and then there have been incremental improvements such that in 2000, so this is the latest study, 96% of children are surviving. This is just the most awesome success that we've seen in treating any cancer, let alone childhood cancer. And it's a real tribute to families and patients who've entered large-scale clinical trials that have allowed us to improve the outcome of these children. So what do I mean by large-scale clinical trials? Really, we've been using combinations of chemotherapy drugs, drugs that kill leukemia cells, but they also kill normal cells. It's a triumph of empiricism, really, that gradually we've been able to get better and better. But these drugs have side effects, especially in children. There are effects on the growing heart, there are effects on growth velocities, there are effects on the gastrointestinal tract, effects on immunity. A combination of the immune effects and the gastrointestinal effects mean that these children often have to spend about 3 months out of a year in hospital. The treatment will last about a year or so. But these drugs often don't work as well in adults. So this just shows the number of cases as a function of age for leukemia. And you can see that we always think of leukemia as a disease of young people, often, of children. But these are the male-female rates. Male-female rates. So this is rate per million, rate per 100,000, and these are total number of cases in bars that we see. And you can see the rate actually goes up quite a lot as you get older. The rate really takes off when you're about 70. And in an aging population, this is important. There are about 2,500 to 3,000 cases, 10 times as many in adults as in children. 80% in the over 65 age group, median diagnosis 78. How are we treating these folk? Well, in the under 60s, this is the outcome from the latest UK trials. These are the best results in the world. And it was very interesting. I was in Birmingham on Friday, where the Americans, the Italians, the French, the British all presented their data. And I can tell you, in our very underfunded health service, we had the best results in the world. But in the under 60s, you can see we're not hitting 96%. In good risk disease, about 63% of patients are alive at 5 years. And you can see the curves plateau off, which means if you're alive at 2 years, you're likely to be alive at 5 years. So this is the under 60s, between 20%, 25% and 60% survival. In the over 60s, I'm afraid the graphs look much worse. What are we doing to improve this? There's a partnership that involves Oxford Radcliffe Hospitals, that involves the university, and that involves the National Institute of Health Research. This is a national body. The other key stakeholders are patient support groups, medical charities, and we mustn't forget the pharmaceutical industry. I took out from the web just a series of patient support websites. There are plenty of these, and their role is being increasingly important in helping us think through what are the things we should be doing in terms of treatment. What are the main issues for patients? The Trust has made a huge investment in haematology and cancer. This is a very impressive new building. We moved in there, the inpatients moved in early summer, the outpatients moved in March, I think, and it's a spectacular facility. It's really fantastic. And we've increased the number of inpatient beds from 15 to 25, and it's made a huge difference. We serve an area of about 2.5 million. So we take patients all the way from Wickham, Wexham Park near Slough, Reading, Swindon, Milton Keynes, I apologise, and Banbury. So it's quite a wide area. The lab that deals with about 1,500 blood samples a day, and these are the number of new cases we see, and we do bone marrow transplants. There's a very important institute that Oxford University built some time ago, and it's really the vision of one man, Sir David Weatherall. He was recruited by Oxford back in the 70s, and he was the first person to bring genetic medicine to the UK, really, in my opinion. And he has been really the pioneer in this field and has spawned a huge number of very eminent clinicians and scientists. The current leader of the Weatherall Institute is a man called Sir Andrew McMichael, and he has been absolutely critical in helping us understand how immunity works and how immunity works in blood diseases. He's also made very important contributions to HIV. So we have some real giants upon whose shoulders we stand. And in particular, the MRC Molecular Hematology Unit studies the molecules that make blood, the production of blood, the science of blood, and it's coupled with clinical investigation with the Trust. And there are some other units in the Trust that also do a huge amount of work. The National Blood Service is involved, and they provide the bone marrows and stem cells, if you will, for bone marrow transplantation. But I just want to come on to one last set of slides, and that is about, I guess now 2.5, 3 years ago, the government set up centres of excellence. They call them biomedical research centres, and they were established by the National Institutes of Health, and Oxford was very fortunate, but I think based on a really excellent track record, it was awarded a biomedical research centre status, one of 6 nationally. The others are in England, are in London and Cambridge. And within this biomedical research centre, haematology or blood has been one of the themes that has been supported because it's been recognised as being a theme where there's outstanding science. So we get about £500,000 a year for support, and we've used that support for clinical research to bring new drugs for the problem that I've been talking about, the problem of treatment of older adults. So we've started clinical trials of novel drugs. We've combined that with very high quality studies to understand why some drugs work, why some drugs don't, why some patients are responding, why some patients are not. It requires an excellent clinical service. It requires research. NHS, university, medical charities, patient support groups. And the aim is to develop Oxford Haematology into a leading centre of excellence, not only for clinical care, but also to forward haematology research and training. And we mustn't forget training, because we've got to train the next generation of doctors and nurses, who can take this forward. So let me just tell you a little bit about what we do. We've divided our blood research into several themes. You can see bone marrow transplantation is there, using new powerful genetic means to make very accurate diagnoses. Transfusion people are involved, and these are the two main types of cancers, blood cancers. And I'm involved in this particular set of conditions. So there's acute myeloid leukemia, myelodysplasia, and myeloproliferative disorders. And all of these give rise to leukemia. Okay, so we have a scientific program, a clinical service, and a trial service. And moving to this new cancer centre has been critical for us, because we can now do proper, large-scale clinical trials, bringing new drugs, getting pharmaceutical industry to say, actually, we have a patient group here that has a need, we have the infrastructure to do the trials, and we have the scientific base to really understand why drugs are working. We also collaborate with Birmingham. They have a large clinical setup. So what are we trying to do in the last 2 slides? I just want to tell you a little bit about what kind of drugs and new things, new thinking. If this was that very early cell and it's trying to grow up into a grown-up cell, well, there's a block, and the block I'm showing by this little bar here. So there are genetic changes that folk have acquired, unfortunately, that stop this going into this. And what we're trying to do is, for young and old, we're trying to develop new, non-toxic drugs to make sure this program occurs, genes, so to reactivate genes that promote normal cell fate, and to inactivate mutant or abnormal gene products. We're using new small molecules, new antibodies, and new drugs that control this process. And they're specifically targeting these very early leukemic stem cells. These stem cells right at the beginning that, when they go wrong, give rise to leukemia. The small molecule inhibitors are very powerful. They're smart designer drugs, and there's one drug in particular called Glyvec, which some of you may or may not have heard, that's revolutionized the treatment of one type of leukemia. It accounts for about 12% of leukemia, but it shows us the way forward. These patients are now living in their 60s, 70s, 80s. They're now living 5, 10, 15 years at home, taking 1 to 2 tablets a day. We have new antibodies or proteins that coat leukemic stem cells specifically, not normal, leukemic cells specifically, and target them for destruction. And we're developing new ways of doing bone marrow transplants, so-called mini transplants. When I first started in blood diseases, bone marrow transplants were restricted really for patients under 40. Nowadays we're transplanting patients in their 50s and 60s. We're doing the odd patient, not common, but the odd patient in their 70s. But I can see that moving forward. We're using cord blood as a source of stem cells. With our young families, nuclear families, 1 or 2 children only, we often can't find sibling donors. So we have to use unrelated donors. And a very potent source of stem cells for transplantation is cord blood. This is the blood that's in the placenta and the cord that links the fetus to the mother, because those blood cells are very potent, very powerful, and they are very well tolerated by adults. So these are new ways of doing things. There's a local need, of course, for Oxford patients. There's a regional need, but most important, there's a need for all patients that we carry on developing these therapies.